Good morning, everyone. First of all, I want to say a big thank you to the VAO for giving me this opportunity to share my knowledge and also my passion for orthodontics. Now, furthermore, the topic that I want to share today is the biomechanics of minuscules in AMAS space closure. My presentation is divided into 7 sections. Especially in the 7th part, I will talk about my case and when I'm using multiple TADs and how I can put my case in the control. When it comes to minuscule mechanics, the first thing we need to do is identify the active unit. Look at these two pictures. Two pictures has the same thing is we put the minuscule between the tooth number 5 and number 6. But in the first picture that we use segmental arch wire, and in the second picture we use continuous full-sized arch wire goes along the anterior and posterior teeth. So the question is, which is the active unit in every situation? In the first picture, we can see that we use the segmental arch wire that only goes the anterior teeth. So the anterior and posterior teeth that they are independent. So in this case, the active unit is only the anterior segment. But the question is how the full system operates in the active unit. We're gonna put the power chain from the hook into the minuscule, so the line of action of the force goes like this in the picture. And we also see a distance from the center resistance to the line of action. So we have the clockwise moment like this. With this kind of the force system at the CR, the anterior segment will move distally and also rotates clockwise. What is gonna happen if we use a continuous full-sized arch wire or with a stop mesial to the molars? In the second case, we use the full-sized arch wire goes along the anterior and posterior teeth, so they connected two segments together. So in this case, the active unit is total arch. How the force system operates in the active unit? Because of the active unit is the total arch, so the center resistance moves distal of the tooth number 5, and also we can see the line of action of the force has a distance from the CR, so the force system goes like this. So we have the force and also clockwise moment. So with this kind of force system, the total arch will move distally and also it will rotate clockwise. The question is, if we don't use a continuous full-sized arch wire, instead of it, we're gonna use undersized arch wire. Look at this picture. What happens if we use an undersized continuous arch wire? Because the wire has plate within the bracket slots, the connection between anterior and posterior segment is loose. In this scenario, the active unit is divided. The anterior segment reacts first, and its movements subsequently affects the posterior segment, so they are two separate active units. from these examples, it leads to the definition of the active unit and reactive unit. Imagine that we want to retract the canal. Using the first molar is the anchorage, and the coil spring is pulling from the first molar to the canal. Look at. As you can see, the canal will move distal, but also the first molar will move medially because of the reciprocal force. We know it from Newton Rule 1. So that is the reason why in traditional mechanics we not only just look at the active unit but also reactive unit. But there is something different in mechanics with minuscules. We replace the first molar by minuscule and still retract the canal by using coil spring. So look at. With minuscules, the scale itself becomes the reactive unit. It completely absorbs the reciprocal forces. This simplifies our work significantly. We only need to focus on designing the force system for the active unit without worrying about adverse effects on anchorage teeth. Come back to the previous case. Identify the active unit and the reactive unit in the case that we use undersized arch wire. The minuscule putting between the tooth number 5 and number 6 is the reactive unit. But we have two active units. The first active unit is the anterior segment, and it has a role called mean effect. And the second active unit is the posterior segment, and it has the role called side effect. Let's delve deeper into using an undersized wire like stainless steel 16 by 22 in 18 slot. Closure without minuscule or with minuscule are different from two aspects. The first thing is the change of the line of action of the force. It always includes the vertical component. And the second thing, with minuscule, we can remove the reciprocal force that activates on the posterior teeth. Many clinicians assume that because they are pulling from the minuscule to the anterior segment, the posterior teeth will remain stationary for maximum anchorage, and the vertical force component will intrude the incisors, helping to prevent the roller coaster effect. But is this what actually happens? When a flexible arch wire is used throughout the dental arch, the anterior and posterior segments will not be rigidly linked. So, the first active unit is the anterior segment. Transposing the force vector to the anterior CR creates a clockwise moment. This causes the incisors to extrude and tip lingually, while the canals intrude slightly and tip distally. This is the exact opposite of what we want. We wanted intrusion, but we get extrusion and lingual tipping. To conclude, we have at the incisors, it will extrude and lingual tipped. And with the canal, we have slight extrusion and distal tipping. At this time, we might ask, how do the posterior teeth move? Look at this picture. An undersized arch wire goes along the dental arch, and we also put in the minuscule between the tooth number 5 and number 6, and also create the line of action of the force to retract the anterior teeth like this, and see what is gonna happen. As the anterior segment extrudes and it tips lingually, it creates an angle or a V-bend in the arch wire related to the posterior segment. This triggers geometry cast 3 mechanics as described by Dr. Burston. With cast 3 geometry, we know that the force system goes like this. But pay more attention to the posterior teeth. This geometry creates an intrusive force and a mesial tipping moment on the posterior teeth. So what is the result? The molar tip mesially and intrude. So we have anchorage loss and effect opposite to the desired anchorage. Let's observe again. So to conclude, when we use an undersized wire, the incisors will slightly intruded and lingual tipped. The canal is slightly intruded and distal tipped. Premolar is intruded, mesial tip, and molars will mesial tip. So from all of that, it will develop a lateral open bite, and also we can be lost anchorage at the posterior teeth. This is common clinical failure. We retract heavily to reduce protrusion, but the molars tip mesially and intrude, creating a lateral open bite and losing extraction space. We wanted anchorage and anterior intrusion, but instead of it, we got anchorage loss, anterior extrusion, and a lateral open bite. Why? Because of the underside wire and the resulting geometry 3 mechanics. So how we can fix this? First, we can use stiffer wires, like we can use stainless steel instead of using nitrile to resist deformation. Second, counteract the adverse moments. You can add a slight reverse curve about 5 degrees to the main arch wire. However, they can further intrude posterior teeth. So the most effective solution is using a secondary reverse curve arch wire in the auxiliary molar tube ligated to the anterior segment. This creates an intrusive force and a tip back moment on the molars, perfectly counteracting the adverse effects of geometry 3. Alternatively, crimping a high anterior hook reduces the initial coxswain moment on the anterior segment. As you can see, a reverse curve arch wire creates an intrusive force in the anterior segment and also an extrusive force and clockwise moment in the molars. We move on to another section. So now, what if we use a full-sized arch wire? The active unit is the entire dental arch. When we use a full-sized arch wire, high friction essentially locks the wire into the brackets, making the entire arch act as a single, rigid active unit. We must evaluate movement based on the CR of the entire arch, usually located around the premolar roots. Transposing the retraction force to the full arch center resistance creates a clockwise moment for the entire arch. Hence, the anterior segment moves down or extrudes, and the posterior segment moves up or intrudes. The occlusal plane rotates and becomes steeper. Interestingly, the molars tip distally, which seems counterintuitive since we are closing space, but this occurs due to the full arch rotation. When using full-sized arch wires, two things are crucial that we have to pay attention to. First, you must include the second molars in the appliance. If you don't, the first molars will intrude and tip distally, and then creating a severe step between the tooth number 6 and number 7. Look at the picture, you can see a step between the tooth number 6 and number 7 because of the rotation of the upper dental arch. So always round the bracket at the second molar when we're using a full-sized arch wire. Second, because the friction is extremely high, the extraction space might open distally. To counteract this friction, at a light internal power chain, example 50 to 100 grams, from the molars to the anterior hooks. We move on to the section 4, the alteration in the occlusal plane during AMAS retraction supported by TADs. So let's take a look at this article that comes from Korea. There are two places that we put the minuscules. We called low OMI when we put the minuscule between the root number 5 and number 6, and high OMI when we put the minuscules higher, measure to the root number 5. And we're gonna examine two cases with a large extraction space when we extract the tooth number 4. We always use short hooks about 3 millimeters in both cases. The results with low OMI. When the extraction space is so large, we can see the significant occlusal plane rotation, and the occlusal plane comes steeper. And this phenomenon still happens when the extraction space is so small. It means that the occlusal plane continues to steepen. But with high OMI, there is something different. When the large extraction space, it still has the same phenomenon, is that the occlusal plane comes steeper, but not too much, just light and small. However, the main difference happens when the extraction space is small. At this time, you can see the occlusal plane will rotate counterclockwise. This phenomenon is opposite to the previous. To conclude, The height of minuscule affects the occlusal plane. The research shows that a low OMI, the minuscule between the roots number 5 and number 6, consistently steepens the occlusal plane, and a high OMI tends to flatten or counter-rotate the occlusal plane. On the left is the low OMI, and on the right is the high OMI. So from all of those theories, we go to the section 5, how you can achieve efficient air mass retraction with TADs. There are multiple factors that we might consider when we want to put the minuscules. It's about incisor axial inclination and also anterior vertical dimension or posterior vertical dimension, and really important, occlusal plane inclination. We will examine the patient like this. So look at the upper incisors. We can see they are so proclined, and after the treatment we want to upright the upper incisors. So in this case we want to use tipping movement. So that is the reason why we just want to use a low hook. And when the patient smiles, we can see a reverse smile line and insufficient maxillary incisor space. So after the treatment, we need to increase the anterior vertical dimension. So using low OMI or IGC minuscules to steepen the occlusal plane and increase maxillary incisor space. And look at the cephalofilm. We can see that the patient has the increased posterior vertical dimension with the open mandibular rotation. So we really want, after the treatment, we really want to decrease this. So we're gonna try to use a large full-size attire. But remember, when we use the full-size attires, the friction is extremely high, so it will tip the total arch distally. That means it will create more space. So to stop it, we need to supply the internal power chain. And always remember to bond the bracket on the second molar to avoid the step between the tooth number 6 and number 7 because of the rotation of the total arch. We move on to the section 6. The question is, when you see the design of the appliance with any minuscules on the reality, how you can predict the tooth movement. To truly understand and predict tooth movement with any appliance, including complex minuscule setups, we can follow these 5 steps. The first, identify the active unit. Second step, identify the center of resistance. Step 3, determine the force vector from the minuscule. And step number 4, transpose the equivalent force system to the CR. And the step number 5, deducing the resulting movement. So let's apply the 5 steps with these examples. At the example 1, extraction the tooth number 4 and putting a low OMI between the tooth number 5 and number 6. And also using a full-sized attire, how we can predict the movement of the teeth in this scenario. The first thing we need to do is identify the active unit. Because of the arch wire is a full-sized arch wire, it goes along the anterior and posterior teeth, so they are connected together. So in this case, the active unit is the entire maxillary arch. Step 2 is we have to identify the center resistance of the active unit. In this scenario, the center resistance is the maxillary total arch, so it locates between premolar roots, like in this picture. Step number 3, determine the force vector from the minuscule. Because the power chain it comes from the hook of the arch wire come to the minuscule, so we have the line of action of the force goes like this. Step number 4, transpose equivalent force system at the center resistance. As you can see, there is a distance from the center resistance to the line of action of the force. So the force system at the CR we have like this. Step number 5, deducing tooth movement. So with the force system that activates at the CR like this, we have the incisors will extrude and the molars will intrude, and also the occlusal plane rotates clockwise movement. And please remember to bond the bracket on the second molar when we use the full-sized arch wire. Another example, in this case we retraction using an IZC minuscule with high placement and a full-sized arch wire. How we can predict the tooth movement in the upper arch? Step 1, identify the active unit. Because of the full-sized arch wire goes along the anterior and posterior segments, so they are connected together. So the active unit in this scenario is the total arch. Step number 2, identify the center resistance of the active unit. The center resistance in this case is the total arch. So we have the center resistance goes like this in the picture. Step number 3, determine the force vector from the minuscule. There is a coil spring. It comes from a hook into the minuscule, so it's gonna create the line of action of the force like this. Step number 4, transpose equivalent force system at the center resistance. As you can see, there is a distance from center resistance to the line of action of the force, so it transposing the force creates a counterclockwise moment like this. Step number 5, deducing tooth movement. The total arch moves distally and also occlusal plane becoming flattened. So from the beginning until now, so far I only analyzes in the scenario that we want to have arm mass retraction. So what is gonna happen if we only distalizing the canal first and afterwards we're gonna retract the incisors? So what is exactly with this kind of mechanics? In this case, we're gonna put the minuscule between the tooth number 5 and number 6, and also to create the line of action of the force to retract only the canal like this. So to predict the movement of the canal, we need to identify the force system that happens at the CR of the canal. So with the force system at the CR of the canal, it will move distally and also rotates clockwise. And to predict the movement of the posterior segment and anterior segment, we have to evaluate the geometry that creates from the slot of the canal with the slot of the posterior segment and also anterior segment. So to easily imagine, we can see that the posterior segment will intrude and counterclockwise, and incisors will extrude. And finally, we move on to the seventh part. Today, I would like to discuss a clinical strategy to resolve conflicting factors in minuscule selection. We will focus on the simultaneous coordination of multiple TADs to achieve predictable results in complex cases. This is case 2 by maxillary protrusion with severe gummy smile and crowding. A 16-year-old female patient presented with a deep complaint lip protrusion and a gummy smile. She also exhibited moderate to severe crowning in both arches. Extraoral examination reveals a convex profile and significant lip incompetence. Upon maximum smile, we observed an excessive gingival display of approximately 5 mm. This gummy smile was a major concern for the patient, significantly affecting her confidence and social interactions. Intraoral findings included a class 2 molar relationship, moderate crowding, and localized crossbites like teeth 1-5 and teeth 4-5. The mandibular midline was shifted 1.5 mm to the right. Cephalometric analysis confirmed a severe skeletal class 2 pattern with an A and B angle of 6 degrees. The SNA was 86 degrees, indicating a protrusive maxilla. Vertically, the patient is hyperdivergent with an FMA of 36 degrees, contributing to an increased lower facial height. And the panoramic radiograph of the patient, we can see the 4 wisdom teeth, skeletal class 2 relationship with A and B is 6, backward mandibular rotation, contributing to an increased lower facial height, which was an underlying patient complaint. The overhead of the patient is 5 mm and crowding from moderate to severe with the maxilla is 5 mm and mandibular is 7 mm. We also had tooth crossbite and the mandibular midline shifted to the right by 1.5 mm. And patient revealed gummy smile and increased vertical maxillar dental alveolar height. We can assess it through our cephalometric analysis. And we have convex profile with bimaxillary lip protrusion. Our plan involved the extraction of all four first premolars. To manage the maxilla, we utilized two ICC minuscules for maximum anchorage retraction and one anterior minuscule placed between the central incisor for vertical intrusion. This combination aims to reduce protrusion and the gummy smile simultaneously. And this is the patient at the start. In the first 6 months, we extract 4 premolars. The extraction spaces were ready for closure. Here you can see the placement of the T80s and the initiation of AMAS retraction. Let's analyze the full system. The red dot represents the center resistance of the 6 anterior teeth. The anterior minuscule generates an intrusive force of 80 grams. Since this force passes anterior to the CR, it creates a counterclockwise moment tending to fair the incisors. But simultaneously, the posterior ICC scales generates a distal oblique force of approximately 240 grams. This force passes posterior to the CR, creating a clockwise moment. This moment acts to tip the incisors lingually. When we combine these systems, the clockwise and counterclockwise moments effectively cancel each other out. The resultant force is a distal and upward vector of 183 grams. At a 25-degree angle, this allows for bodily translation of the anterior segment, achieving both retraction and intrusion without unwanted tipping. After 18 months of treatment, we achieved space closure and ideal torque control. A minor gingiviectomy was performed post-orthodontics to further refine the gingival contours. The results are striking. We see a significant reduction in lip protrusion and dramatic improvement in the gummy smile. The inline relationship is now harmonious and the patient's profile is much more balanced. Final intraoral views show an excellent Cas1 relationship is stable. The crowning and cross-spines are fully resolved. We can see the excellent change of the patient between the initial and the final of the treatment. The comparison of the panoramic radiograph and cephalometric film look at the superimposition of the patient. We can see the reduce of the protrusion of the upper lip and also the lower lip. Comparing the data, the A and B decreased from 6 to 3 degrees, helped to correct the CAS2 skeletal discrepancy, and the FMA decreased by 3 degrees, means the mandible rotate counterclockwise after the treatment. The first thing that we can see is the point A retraction helped to correct skeletal relationship to CAS1. The second thing, bodily retraction and simultaneously intrusion of the maxillar incisors. Finally, the best thing that I can share is the patient is highly satisfied with her smile, feeling more confident, and she told that she is ready for her upcoming university journey. And this is the references that I might use in my presentation.